Okay. Okay. Let's move on to the next question. So a 38-year-old IV drug abuser presents with a history of malaise and rigors since 1 week. His temperature on admission was 38.5 degrees Celsius. Examination revealed a significant pansystolic murmur, which was loudest at the left sternal border. 3 sets of blood cultures were taken. The transthoracic echocardiogram showed vegetation on the tricuspid valve with moderate tricuspid regurgitation. Which of the following organisms is most likely to be positive in blood cultures? So, what is the answer for this question? So, how would you approach this question? So, this is an IV drug abuser, which is the most important point in this question, right? IV drug abuser is a very, very important point in this question because the organism depends on that. We all very well know this is what we are discussing is on infective endocarditis, right? We are discussing on infective endocarditis. So we need to remember what organism is more common in certain special situations, right? So in this condition of IV drug abuser, which option will be the correct one? This is a very basic question. I would like all of you to answer. Yes. So before we come to the answer, what we'll do is we'll discuss something about, we'll just recollect something about infective endocarditis. We have a detailed chapter on this. I've taken it earlier also. But just to reinforce and, reiterate here, we'll just have a small discussion on infective endocarditis. Yeah. So infective endocarditis. What is the diagnostic criteria called? It's called modified Duke's criteria. Modified Duke's criteria, right? So what does this have? This has major as well as minor criteria. Major as well as minor criteria, right? So what are the major and minor criteria? So if there is an usual organism, if it's streptococcus or staphylococcus, some organism that you expect to, or an enterococcus that you expect to actually produce endocarditis, if the culture should be positive for that, then it comes under the major criteria. Okay, blood culture is positive for infective endocarditis. Then there should be an evidence of endocardial involvement. Also, there is one more point which says there should be evidence of Coxiella burnetii. Okay, there should be a single positive culture of Coxiella burnetii, or there should be an increase in the Ig immunoglobulin titers more than 1 in 800 for this Coxiella burnetii. This also comes under the major criteria. So blood culture positive for infective endocarditis, evidence of endocardial involvement, Coxiella burnetii, culture identifying Coxiella burnetii, or there's an increase in immunoglobulin titers of more than 1 in 800 positive for Coxiella burnetii. Then all these come under major criteria. So what is the minor criteria? The patient should have a predisposing cardiac lesion, say an artificial heart valve. Artificial heart valve. Okay, or immunosuppressed patients. Immunosuppressed patients, or they're having a valve lesion like AMS, MR, or AR, or MS. They're all, predisposing factors. Then the temperature should be high. They should be having a fever. Then they should have also some vascular phenomena. They should have vascular phenomena and immunologic phenomena. So what are the vascular phenomena which you should remember? Named ones, Janeway lesions. You should not confuse between the vascular phenomena and the immunologic phenomena. So vascular phenomena will be something like Janeway lesions, but the immunologic phenomena will be painful nodes. Painful nodes. You must remember Osler's nodes. Osler's nodes, which are painful. And what else? Roth spots. Roth spots on the retina. All these are important. Okay, so Janeway lesions, Osler's nodes, Roth spots, these are all important. You must also remember Osler's nodes are painful. And you must have some microbiological evidence. There is positive culture, which are not involving the major organisms. Some minor organisms that which are not definitely found to be associated with major criteria. Then those organisms you have to have a microbiologic evidence. So you now know the major and the minor criteria. So when do you have a definitive diagnosis of endocarditis? When there are 2 major criteria, or 1 major and 3 minor criteria, or just all the 5 minor criteria. Okay, you need to have both the major criteria, 2 major criteria, or you must have all the 5 minor criteria. You need to remember easily 2 major criteria or all the 5 minor criteria. Combining both, 1 major, 3 minor. Okay, this means that there is a definitive diagnosis of infective endocarditis. When will you say that there is a possible diagnosis of infective endocarditis? There is only one positive criteria, one major criteria, and one minor criteria. Okay, in that case, you say that there is a possible infective endocarditis, or the patient has any three of the minor criteria, say fever, vascular phenomena, and microbiologic evidence. Okay, so in this case, this means that there is a possible diagnosis of infective endocarditis. Definitive diagnosis, 2 major criteria, 5 minor criteria, or 1 major, 2 minor criteria, 3 minor criteria. Okay, for the possible diagnosis, you need to have 1 major and 1 minor criteria, or 3 minor criteria. Okay, this is very, very important to remember. Okay, so let us see about some special situations, what you must remember. So I'll just write it out. You will find out what is the organism. So what is the infective endocarditis most common organism in neonates? For IV drug abusers, then prosthetic valve endocarditis, and in colon cancer. These are very, very possible MCQs. These are very high yield questions also. So you need to remember what are the most common organisms in neonates, IV drug abusers, prosthetic valves, and in colon cancer. So the first one, in neonates, it will be Staph aureus. Okay. In IV drug abusers, if it is a right-sided valve, it will be most commonly Staph aureus. This is the most common also. But if it is left-sided, there is a possibility for Enterococcus. Okay, there is a possibility for Enterococcus. Okay, or Pseudomonas. Enterococcus or Pseudomonas. You must remember this, Enterococcus or Pseudomonas. And prosthetic valve, which is more common, if it is less than 2 months after the prosthetic valve implantation, then it will be CORS, coagulase negative organisms. So it will be CONS. If it is more than 2 months, then it is more common Strep viridans. It is like any other valve. Okay, so it will be most common Strep viridans. In colon cancer, you need to remember the most common organism is Streptococcus bovis. So in neonates, Staph aureus, IV drug abusers, if its right side is involved more, it will be Staph aureus. If the left is involved more, Enterococcus or Pseudomonas. Prosthetic valve, less than 2 months, CONS, more than 2 months, Streptococcus viridans. If the patient is having a colon cancer, the most common organism will be Streptococcus bovis. Okay, Streptococcus bovis. So in this patient, what do you find? He is an IV drug abuser and he has an infective endocarditis on the right side. That's a tricuspid valve, right side. So the most common organism in this patient will be Staphylococcus aureus. Staph aureus will be the most common organism involved. Okay. So while we are touching about this topic on infective endocarditis, there is one more question where you will get very, very commonly asked about is prophylaxis. When do you actually give the patient prophylaxis? So this is very common complicated question. They will ask you that the patient is going for a dental procedure. If he has the prosthetic valve, should you actually give the patient prophylaxis or not? So when will you give the patient infective endocarditis prophylaxis? It is indicated when the patient has had a prior history of endocarditis, when the cardiac valve disease in a transplanted heart, when the patient has undergone a heart transplantation and is having a requirement for an endocarditis prophylaxis, then you should definitely give the patient prophylaxis. If there is an unrepaired cyanotic congenital heart disease or an incompletely repaired cyanotic heart disease, then you give the patient prophylaxis. Then congenital heart disease repaired using a prosthetic material. If there is a prosthesis for any reason in the heart, say it be it a cardiac transplant or a heart disease repaired through a prosthetic material, say like grafts or a prosthetic heart valve. Shunts, we remember we have discussed in PDA. So that, or a prosthetic heart valve because of regurgitation or severe stenosis, in those patients, you have a prosthetic heart valve, or if you have a valve repair using a material prosthetic, and if there is any prosthetic, then you should definitely give prophylaxis for the patient. Okay, you should definitely give prophylaxis for the patient. The common things where it will be confusing is if there is an atrial septal defect or there's hypertrophic cardiomyopathy or a mitral valve collapse with regurgitation. For all those things, you don't need to actually give prophylaxis for the patient. Okay, so this is a very, very high yield slide that I would like all of you to remember. Infective endocarditis is very favorite topic for the examiners for them to question you on. Okay. Yes. So moving on to the 5th question.